I have a slightly contentious topic of hypoplastic MDS. It's a fairly gray area, and there's a little bit of ambiguity about diagnoses, about treatment. So my voice is soft, not just because I'm in UK sleep mode, but also because there's some diffidence about what I'm going to talk about. But I'll take a fairly convoluted route because I'll start off talking a little bit about aplastic anemia, and then I'll branch out to stressed hemopoiesis, and that'll form the bulk of my talk. And then finally, I'll try to see if I can link up. A lot of it is hypothesis, and see if stressed hemopoiesis links up with hypoplastic MDS. So firstly, this is a slide of patients with bone marrow failure syndrome presenting with cytopenias. On this side, you have this whole spectrum of mainly monogenic disorders associated with inherited bone marrow failure. So you have DNA repair disorders over here, you have telomeropathies over here, you have ribosomopathies over here, all able to manifest with bone marrow failure. And on this end over here, you have conditions such as idiopathic aplastic anemia overlapping with PNH, and considered to be acquired disorders. I have a slight misgiving about this slide because I don't think these disorders are purely monogenic, in that they may have a monogenic mutation, an inherited mutation causing bone marrow failure, which has a propensity to progress towards MDS, but it almost invariably requires a second hit, sometimes a third hit, either an environmental factor or a secondary acquired mutation. Likewise, I don't think these disorders that sit on this end, PNH and aplastic anemia, are all necessarily purely acquired in that sense, because there is a certain amount of molecular component to this disease, a certain amount of genetic component to this disease, which shows some kind of inherited susceptibility. For example, patients with aplastic anemia, a third of patients with aplastic anemia will have short telomeres, and very few of those actually have proven telomere gene mutations. Again, patients with aplastic anemia have gene expression profiling, show they have a pro-inflammatory profile. So again, there is a certain amount of genetic susceptibility in these patients, on top of which they develop aplastic anemia, all of which they converge over here. This mouse is not working, one sec. Yeah, so the acquired ones and the inherited ones from this side converge with a second hit or a third hit to develop some kind of MDS, and there's further clonal evolution, all with a propensity to progress towards acute myeloid leukemia. And somewhere in between, we have this blue shade over here, which is an overlap between aplastic anemia and MDS. And we'll try to ascertain, see if we can make more sense of this. So we have patients who can have normal blood counts. And earlier in the day, I think we had this beautiful talk about histology being so important. And often we're looking for simple clues, very, very simple clues. Sometimes just looking for evidence of macrocytosis. And things like that. Subtle signs of dysplasia not meeting diagnostic criteria, again, very commonly used in reporting. And these are patients who often we consider them to have some sort of clonal hematopoiesis. But once they develop cytopenias, you progress to, you cross this line, you are in this territory of cytopenias, which is either aplasia or dysplasia. And when you have dysplasia that is limited to 10% or less, it is mainly either CHIP territory, ICUS territory, CCUS territory, or if it's a hypocellular bone marrow, then it's aplastic anemia. And once the dysplastic component has exceeded 10%, then you progress to MDS. And somewhere in between this pink shade shows that the bone marrow is hypocellular. So when you have a hypocellular marrow with features of dysplasia and some other signs that go alongside with it, we'll like to call this as hypoplastic MDS for now. This is a revision of Cometa criteria. We all know, and I highlight this only because the bone marrow cellularity is deemed to be less than 25% for the purposes of diagnosis. The very traditional teaching and the purists amongst the histopathologists will say that rule of thumb is that the bone marrow cellularity is 100 minus your age. So if you're 70 years old, the cellularity of your bone marrow should be 30. And this is where you have a slight exception, and it further comes to light when I go further down the slides, and we show how there's a slight difference between this definition. We've seen what happens following immunosuppressive treatment with horse ATG and cyclosporin in aplastic anemia. The likely side effects, complications, we're talking about long-term complications. Nearly half of patients will develop a PNH clone. About 10 to 15% will have a clone that's large enough to qualify as a hemolytic PNH. We see cytogenetic anomalies in nearly one-fifth of patients who've been treated with immunosuppressive treatment. And a third of patients relapse. And these are features that are known to be associated post-immunosuppressive treatment. And this is the category that we further want to delineate. These relapse patients, are these pure aplastic anemia relapses, or is there something else happening over there? I now branch out into some features of clonal hematopoiesis and stress hematopoiesis. Now, CHIP is considered to be present in nearly all patients with aplastic anemia, and this has been borne out by numerous studies which have shown, particularly X-linked inactivation studies have shown that nearly all of the progeny cells that come out from the bone marrow in aplastic anemia come from a very few hematopoietic stem cell parentage. And the logic or the hypothesis that has always worked is that these are the stem cells that have survived. So they have some kind of a survival advantage, almost following the Darwinian hypothesis, survival of the fittest. These cells survived, and they are the only ones that are then left to repopulate the bone marrow in a bone marrow which is otherwise empty of all other blood-making cells. And so clonality actually becomes a mechanism of escape for these cells. And that's the presumed mechanism that we work with when we talk about clonal hematopoiesis. We see two main mutations that commonly affect patients with aplastic anemia. One is the PNH, which again is considered to be an escape mechanism in aplastic anemia. In fact, Dr. Young sitting over here described this first in 1992, actually. And then we have this loss of HLA alleles, which sits on chromosome 6p. And these two are fairly specific. Big A mutation seen in nearly 50 to 60% of patients, and changes to HLA class 1 genes sitting on chromosome 6p in nearly 20% of patients. They're almost considered pathognomonic in aplastic anemia and considered to be an immune-mediated survival of the hematopoietic stem cells. They're not seen in any other inherited bone marrow failure. That's a lie. Very few patients with inherited bone marrow failure syndromes can present with a small PNH clone. But generally speaking, the dictum is that inherited bone marrow failure syndromes don't present with these immune-associated features of mutations. Now, what happens to this HLA class 1 alleles? Essentially, we see two kinds of changes, and they are kind of fairly box standard. One is we see that there is a pathogenic defect happening in one of the arms over here, and there is very quick uniparental disomy and copy neutral heterozygosity taking over, so that you have a certain loss of ability to present antigens because you have copy neutral LOH. And this is fairly frequently seen. And the second defect that happens is obviously an acquired missense mutation at the loci of 6p. So between these two, 6p uniparental disomy and acquired mutation are fairly frequently seen in hematopoietic stem cells in aplastic anemia. And it's considered that, because of this change that happens at this loci, the ability of the hematopoietic stem cell antigens to be presented effectively is lost, and hence they survive, much like the PNH clone, which survive because there is a loss of the GPI-anchored proteins. This by itself is not the only mechanism, because there are different mechanisms, but it just explains why there is an immune escape when you have PNH or HLA genes being mutated in aplastic anemia. Now, mutations and 6p copy neutral LOH is a fairly recurring phenomena, and they usually tend to happen at very specific loci, particularly this B1402, 4002. And they are also the ones which are most significantly present, overrepresented HLA alleles in aplastic anemia. Now we look at the mutation landscape of what is considered to be ARCH or perhaps CHIP and aplastic anemia over and myelodysplastic syndrome. And you see this whole different profile of mutations coming through. Clearly DNMT3A and some epigenetic genes predominate when you're thinking about ARCH-associated mutations. And when you think crossover to this side and you have aplastic anemia, and PNH makes up nearly 60% of mutations. And then you have a host of other smaller mutations that are seen, including BCOR and 6p copy neutral LOH. And just slightly coming on to this side, you have this, we've heard this beautiful talk about mutations in MDS, starting off with TET2 mutations. The second most frequent would be the spliceosome mutations and followed by epigenetic mutations. All of these mutations are fairly diverse and separate. You know, it just shows that the pathogenetic mechanisms involved with normal aging, acquired aplastic anemia and MDS are so different. Now we look at the mutation landscape between what is normocellular or hypocellular MDS, hypoplastic MDS, and aplastic anemia. And if you just look at this slide broadly, you start to see a pattern. This part of the slide matches up with aplastic anemia, and perhaps this part of the slide matches up with what is considered to be hypercellular MDS. And it just almost tells you that perhaps there are two types of hypoplastic MDS. One perhaps is a hypoplastic MDS that more mimics aplastic anemia, and you have another type of hypoplastic MDS that perhaps is more veering towards your normal MDS. And what is it that differentiates the two? How do you differentiate? Firstly, you need to define what is hypoplastic MDS, then you need to diagnose it correctly, and then you need to define what is low and what is high risk if you're going to talk about two different mechanisms over here. And this is a small attempt over here to see if these are very limited number of case reports and retrospective studies that have given us this data. Cytogenetic abnormalities are seen in nearly 50 to 60% of patients with hypercellular MDS, not so much with hypoplastic MDS, it's about 30 to 40%, and much lesser in aplastic anemia, about 10 to 15%. You see a host of other cytogenetic abnormalities MDS, including monosomy 7 to trisomy 8 to del20q-5 to complex cytogenetics. Whereas in hypoplastic MDS, you're more associated with just a few associated abnormalities. And in aplastic anemia, you're essentially down to mainly monosomy 7, trisomy 8, trisomy 6, del13q. And often the size of the mutations in normocellular MDS is often the VAF is in excess of 50, 60, 80%. Whereas in hypoplastic MDS, it's usually in the range of 20 to 30%, and in aplastic anemia, it's often less than 10%. When you talk about mutations, spliceosome mutations almost exclusively are seen with hypercellular MDS, sometimes occasionally seen with hypoplastic MDS, and rarely seen with aplastic anemia. Similarly, epigenetic mutations and other cohesin stack 2 mutations seen mainly with hypercellular MDS, but not so much with the hypoplastic elements of bone marrow failure, be it aplastic anemia or hypoplastic MDS. And pathogenic germline RTL mutations can be seen with hypoplastic MDS and can be a presenting feature of telomeriopathy. So you're seeing slightly two different profiles of hypoplastic MDS, certain features that are more in keeping with normocellular or hypercellular MDS, and certain features that are more in keeping with aplastic anemia. Let's further try to kind of break up these mutations. Now, we broadly know that the percentage of people developing secondary MDS or AML post immunosuppressive treatment in aplastic anemia is about 10 to 15% at 10 years. But it's not strictly that. People who have MDS associated mutations actually have significantly higher risk of developing MDS. And when we're talking about MDS associated mutations, we're talking about RUNX1, ASXL1, monosomy 7. These people are significantly prone to developing MDS and AML much earlier. The incidence could be as high as 40% at 5 to 7 years. Whereas people who have PIGA and BCOR associated mutations, the more benign mutations, the incidence is much, much, much lower. Again, a point to make over here is that age-related mutations, particularly low-level DNMT3A mutations, where the VAF is less than 10%, does not predict progression to MDS or AML. We'll look at thrombopoietin levels in aplastic anemia and MDS. Now, thrombopoietin levels, very generally speaking, as is seen in this slide, are negatively regulated by the number of platelets that you have in your peripheral blood counts, as well as the number of megakaryocytes that are seen in the bone marrow. Patients with aplastic anemia usually tend to have very, very high TPO levels, as opposed to patients with ITP, who usually tend to have increased number of megakaryocytes in their bone marrow, and hence, by inference, lower TPO levels. Patients with low-risk MDS usually tend to have variable levels, could be high or could be low, and patients with high-risk MDS usually tend to have low levels. And high TPO levels are associated with response to immunosuppressive treatment. This has been used as a slight prognostic marker in defining if you could get these levels done. And that brings me to what we've been talking about: stress hematopoiesis, mutations, and what's affecting the bone marrow. Hypoplastic MDS is truly an overlap of two conditions between aplastic anemia and MDS, and depending on which end it more veers towards, depending on the cytogenetics, the mutations, the quality of histology, including certain features such as reticulin staining in the bone marrow, can help predict whether this is going to be more MDS territory or this is going to behave like an aplastic anemia, and perhaps you could even get away with giving them standard immunosuppressive treatment. And there are certain features that go along with it. For example, low-risk MDS over here behaves almost every inch like aplastic anemia, in that it's got a higher profile of oligoclonal cytotoxic T lymphocytes. The memory Tregs are reduced in quality and in number. And these are patients who will perhaps even show, although there are no systematic studies that give us this data, but these are patients who could likely show treatment to immunosuppressive treatment and will have the same prognosis as your aplastic anemia patient. As compared to patients who sit at this end of the spectrum, the high-risk end of the hypoplastic MDS spectrum, they usually tend to have a higher number of immunosurveillance cells. They have propensity to progress to AML because of the nature of genetic mutations and cytogenetic changes that are there. And do we have any variable that can reliably help us decide if we're going to categorize our hypoplastic MDS patients based on pathogenic mechanisms, whether it's immune-mediated damage or it's a pre-leukemic transformation? Do we have reliable parameters? Unfortunately not so. It's not very black and white. There's some guidance to that effect, but it's not absolutely black and white. So for example, we know that disorders associated with del13Q are more in keeping with patients who have immune-mediated damage. BCOR mutations, PIGA mutations go with immune-mediated damage. HLA class 1 genes, which are absent or mutated, are in keeping with immune-mediated damage. HLA-DR15 in particular is very, very much associated with immune-mediated damage. And you go to the other end, epigenetic mutations, DNMT3A mutations, monosomy 7. Monosomy 7 is a slight gray again, can be seen with aplastic anemia. And excess of CD34 cells in the bone marrow, excess of reticulin in the bone marrow, all are in keeping with a more pre-leukemic phase of hypoplastic MDS. And we now look at this Trefine, and this is slightly important because this is such a gray area that you're not going to make a diagnosis based purely on genetics or next generation sequencing. So it becomes vital, very, very vital. If any place of all the bone marrow failure disorders where we need the help of a histopathologist is going to be over here, they need to go back and look very, very carefully at the trophine, particularly look at the characteristics of the megakaryocytes. I remember during my training sessions with Barbara Bain about 15 years back, she would start off by saying that, dyserythropoiesis does not count as any dysplastic feature in aplastic anemia. Everybody's allowed to have it. So it's very important to look at other features, particularly megakaryocytes. You see these megakaryocytes over here, they look hypolobated. Yeah, these ones over here, this could do for being a hypolobated megakaryocyte. You see an excess of CD34 staining over here, and you see excess of reticulin deposition. So these are more in keeping with features of hypoplastic MDS. So now let's try to define and dive into the definition. There was a study done initially by Orazai, and he set up this whole workshop, which was conducted over a period of 2 years to see if he could define this entity called hypoplastic MDS. And he primarily used these 4 criteria: morphology, immunohistochemistry on bone marrow trophine, cytogenetics, and SNP karyotyping. It wasn't very freely available then. And then finally, the DNA diagnostics with a very limited panel of genes, mainly just the epigenetic genes. Telomere length was included as well. So based on this, a panel of histopathologists, molecular geneticists, and hematologists blinded in every respect were given a cohort of patients to see how they would class this patient. And based on this, he tried to come up with an algorithm. This was very limited number of patients. He had a small cohort of 38 patients with hypoplastic MDS and small number of patients, just 11 with aplastic anemia. But clearly the thinking was along the right lines in that he set up the preliminary algorithm that we could work on if we had to define this entity called hypoplastic MDS. And subsequent to that, Elisa Bono did this very beautiful work on a very large cohort of patients. And this perhaps is the best data that we have to date that helps us define what is hypoplastic MDS. Nearly 750 patients with normocellular or hypocellular MDS and 450 odd patients with some form of hypocellular bone marrow were classed into this. And she used just basically 3 main parameters between 2 centers in Pavia and with us at King's. In defining them, their clinical scoring was done. Our IPSS was also used only for MDS. Date of diagnosis, their follow-up was accounted for. Cytopenias were documented. Bone marrow cellularity was documented independently by 2 sets of histopathologists. And all the routine bits of immunohistochemistry alongside a 24 gene panel. This was a limited gene panel. It's more than the previous panel, but it's not up to current standards. This is almost 5 years old. And based on this, and the bone marrow cellularity was defined. Now, this is where it's slightly interesting because MDS patients are generally above. Certainly in the West, the median age to develop MDS is, I think it's 72. And cellularity greater than 25% is considered to be, well, technically speaking, it would be normocellular for somebody who's 72 years old. But if patients with MDS were considered to have a hypocellular bone marrow, even if their cellularity was greater than 25%, and their cytopenias were compared with other patients who had cellularity less than 25%, we didn't see any change in terms of being able to differentiate between the 2 diagnoses. So the cellularity per se, as such, did not count so much towards defining it. Either it was considered to be less than 25%, or if it was greater than 25%, so long as it was considered to be hypocellular for the patient's age, was enough to account for going along with this diagnosis of hypoplastic MDS. Near about every parameter that was defined kind of matched up between patients of aplastic anemia, hypoplastic MDS, presumed hypoplastic MDS, and MDS. And I mean, the observations were more or less along predicted lines. There was more anemia in patients who had hypoplastic MDS. Some hypoplastic MDS patients had more profound thrombocytopenia, and chromosomal aberrations were almost strictly along the lines of what you would see in aplastic anemia and MDS. And based on which she came up with these three curves to start with, one which defined MDS, one which defined aplastic anemia, and one which defined as hypoplastic MDS. And you can see this hypoplastic MDS, the green one sits right in between the two. What this hides is actually that it's talking about two cohorts of hypoplastic MDS. And when you separate out these two cohorts of hypoplastic MDS, you realize that the one cohort actually follows the red curve, like the normocellular MDS, and the other curve actually follows the blue line, the flat line below, like as in aplastic anemia. So this brought us to this algorithm of cytological and histological scoring for so to this point, we've just got to the diagnosis. So this could be a long talk, isn't it? The 2 marks given for ring sideroblasts based on a cytological criteria, excess of blasts also got you 2 marks, and the rest of the features. So for example, if you had less than excess of 15% blasts, of less than 15% ring sideroblasts, features of disc granulopoiesis, features of disc megakaryopoiesis all got you 1 mark. If you had fibrosis which is greater than 1, got you another mark. You had features of ALEP, you got another mark. When you combine this with presumed cytogenetic abnormalities and you class these patients, you got a score. When you add up the score, if the score was greater than 2, we call this as the HG score. She decided to call this the HG score. Then you could be fairly certain that this was a hypoplastic MDS based on this scoring system. This had significant specificity of 0.97, so it's got a very high negative predictive value. Not so sensitive, but certainly has got a very high negative predictive value. So this is the criteria that she has proposed, and you need to score more than 2 to consider a diagnosis of hypoplastic MDS. Clearly, having any of these features in a hypocellular bone marrow, ring sideroblasts, blasts, or certain cytogenetic changes, and you score more than 2, you get a feel of hypoplastic MDS. And this is how it pans out. Now you can see this. The red curve is almost the curve of, now both these patients are patients who were considered to have hypoplastic MDS. And the one which has got red almost follows the normocellular MDS cohort, whereas the one which is the green almost follows the curve of patients who have aplastic anemia. And the AML progression and overall survival almost follows a similar pattern. So if you have a HG score which is less than 2, it behaves like aplastic anemia. You have greater than 2, it veers towards normocellular MDS. I think I'll just skip through this slide. Now we'll look at certain treatments. So we've come to this diagnosis of hypoplastic MDS based on hypocellularity and a host of histological features, cytogenetic changes, mutations. What about treatment? We do not have any systematic studies that talk about treatment in hypoplastic MDS. There is one retrospective study from North America and Europe of 15 centers, which talked about 200 plus patients who were treated with horse ATG and steroids, and responses were seen to the tune of 49%. But those were patients who were not treated with cyclosporine, they were treated with steroids instead. And there's been another study since. Data is very patchy and sketchy. A lot of the data is observational study or retrospective studies. This cohort that we're talking about represents hypoplastic MDS as a total percentage of the entire cohort of patients being described. You can see the various treatments that have been tried, mainly immunosuppression with ATG cyclosporin, and then you have the odd thalidomide over here and single agent drugs that have also been tried. Responses have been between 25 to 75%, so it's not hugely informative. That leaves us with this diagnostic algorithm. When you have patients with new onset cytopenia, you have to rule out other causes that could potentially give you these cytopenias. and then you go for a bone marrow evaluation, bone marrow cellularity less than 25% or less than what would have been considered normal for age is a hypocellular bone marrow. More than 10% dysplastic features, you're veering towards MDS. If the cellularity is less than 25% and you're seeing excess of dysplastic changes, you're going into HMDS territory. If there is no dysplasia, but you have then you call it as aplastic anemia, but you have an MTS defining karyotype, you come back and again reclass your patient as being hypoplastic MDS. And how are you going to treat these patients? That's a difficult one. For now, I think we have a broad canvas of what clinical, pathological, and molecular features would combine to give you a diagnosis of hypoplastic MDS. There are two phenotypes in hypoplastic MDS, one of an immune type, which behaves more like aplastic anemia, and one of a pre-leukemic type, which has high-risk genetic and clonal evolution features, which is likely to transform to leukemia. Treatments are mainly directed at managing cytopenias. So you start off with erythropoietin if the erythropoietin levels are low. If these patients are regularly blood transfusion dependent, you would consider iron chelation, and then a host of other things that you could do at managing cytopenias. Anecdotally, people have tried using thrombomimetic agents, especially when they have significant thrombocytopenia and wet bleeding phenotypes. Clearly, we need clinical trials. Immunosuppression would be a reasonable guess, particularly if patients had an immune type of hypoplastic MDS. Young patients can sometimes present with hypoplastic MDS. Another thing to consider is that when patients relapse with aplastic anemia, is it pure aplastic anemia, or has your patient been on this journey where they start off from point A as aplastic anemia, where point C is leukemia, and point B is a halfway point in between hypoplastic MDS in evolution to AML. We will need clinical trials, and there's a lot more to learn about hypoplastic MDS.